This chapter will talk about neurocognitive disorders, and we'll also talk about delirium. So delirium. Delirium is defined as confused thinking and a decreased awareness of the surroundings. This usually happens quickly, between a few hours to a few days. And there's a lot of different things that can cause this. One of the most common things in elderly with delirium is an infection of some type. When you get older, your body has a decreased immune response, so we may not see the same type of symptoms in an infection that you would with a younger person. So that may be, you may have missed the signs and symptoms that you would expect to see, and then the delirium comes upon them, and it's because of that infection. Very common for elderly who have a urinary tract infection to have a big change in behavior, and a lot of times it's because of the delirium. How do we decide if it's delirium or dementia? The onset is clearly a symptom here. The dementia is a slow process. This is a very quick process for delirium and usually has a specific cause for that, and it also usually can be reversed, which is different from a neurocognitive disorder. So can a person with dementia have delirium too? Sure. You have your person with dementia who has a rapid change in behaviors or mood. A lot of times that's caused by delirium. People come to the hospital because they've had a big change and in their dementia symptoms, and underlying you find some type of infection, very commonly a urinary tract infection, and once that is cleared up, they usually go back to their normal state. It's not just the elderly who have this. It can happen in anyone who has a serious illness, can cause delirium. So the DSM-5 says that neurocognitive disorders include those which have a deficit in cognition or memory, and there's a significant change from their previous level of function, and that's a decrease in function. So there are stages in a neurocognitive disorder. A mild neurocognitive disorder, there's a modest decline in level of functioning in one or more of these. Complex attention, which is your ability to track and respond to stimuli or to be able to perform mental tasks quickly and accurately, adding up numbers in your head, paying attention to what's going on if you're driving, being able to look at all the things and make a decision if you need to put your brakes on or not. Executive functioning, which is your ability to sort and prioritize things. This is where we juggle information and where we recognize we've made a mistake and then we go back and we correct it. Learning and memory, those are kind of self-explanatory. Difference in language, and there may or may not be any disturbance in behavior at this point. So major neurocognitive disorder, there's a significant decline in one or more of these areas. Usually it's more than one. There may or may not be behavioral disturbances, and for it to be a major neurocognitive disorder, it has to interfere with their independence in the activities of daily living. So this is a public health problem. People are now living longer. We have ways to treat medical issues that we didn't used to be able to treat. Heart disease has a lot better outcome. Um, Infections, we have antibiotics. So people are living more and more um, to a older age. So this is a growing problem. The statistics show 4.5 million people right now have dementia. And if we don't find some type of treatment for this, the projected for 2050 is 11 to 16 million people. One of the fastest growing populations in our country is the over 100s. Now, COVID took a lot of the elderly people, so that may have changed somewhat, but with COVID under control, I'm sure that will change again. We do have medication that can slow prognosis, but it does not cure the disease. 50 to 60% of cases of neurocognitive disorder are Alzheimer's dementia. It has a slow, insidious onset. It's progressive and deteriorating, and the very first symptom is having memory impairment. So this slide goes to the progressive nature of Alzheimer's dementia. There is changes in the brain, plaques and tangles that can be visualized in that brain and interferes with the ability of the brain to send signals. So first stage is there's no apparent symptoms that the person is showing, but there's the changes in the brain. Start with forgetfulness, problems with short-term memory. People compensate. Maybe they make lists. Maybe they get a calendar, things like that, just to try to deal with that short-term memory loss. You may see depression, and the individual knows that something is going on with them. When you get to mild, this is when people are unable to work, they can't concentrate, and others start to notice that something is going on with them. Mild and moderate, they may confabulate or make up a story to cover up their memory loss, lose awareness of their personal history, and then tend to isolate and be depressed. Moderate ability to do your ADLs, forgetting family and personal information, and then withdrawing. Moderate to severe, disorientated to your surroundings, even if they're familiar, unable to complete your ADLs. Sleep can be an issue, wandering can be a problem, psychotic symptoms are possible, and their communication deficits. Then severe decline is unable to care for yourself. Maybe you're unable to walk, unable to communicate or eat, and this is the terminal stage. Most people, it takes, if they are healthy medically, this can take up to 10 years to go from stage 1 to stage 7. So it is a long process. So this slide just kind of talks about the etiology. We're not sure exactly why this happens, but there's a lot of people with some thoughts about why. So acetylcholine deficits disrupt the cognitive process. One of the medications that's used is a cholinesterase inhibitor. plaques and tangles form in the brain. Plaques are beta amyloid and the tangles are tau proteins. And that's where this can interfere with the ability of the brain to communicate with other parts of itself. Neurons can die. We do know that head trauma is increases your risk. Genetic factors. So there are some types of genetic dementias that form early, possibly late 40s, early 50s, and these can be found on genetic testing at this point. So if you have a young person who is diagnosed, there is a possibility that this might be a genetic disease. The chromosomes 21, 14, and 1 seem to be involved. People who have Down syndrome have a tendency to be diagnosed with Alzheimer's disease sooner in their life than the general population also. So that kind of holds up the genetic theories. So neurocognitive disorder is not always Alzheimer's dementia. There's several different causes that can cause neurocognitive disorders. Vascular dementia, it is due to cardiovascular disease that affects the blood flow to the brain. Someone who's had a stroke, someone who has arterial sclerosis, that can cause a decrease in the ability to get blood where that needs to in the brain. High blood pressure can also be one of the cardiovascular things that can cause this. Frontal temporal neurocognitive disorder, also called Pick's disease, caused by a shrinkage in the frontal and temporal lobes of the brain. TBI, a traumatic brain injury, can cause a neurocognitive disorder. Lewy body dementia. It is similar to Alzheimer's disease, but it progresses fast, and there's a lot of Parkinsonian syndrome symptoms found. Parkinson's disease in the late stages, an HIV infection in the brain. There are sometimes substance and medication-induced neurocognitive disorders. This is due to damage to the brain by the substances, and once they have withdrawn from the substances, you still have that neurocognitive disorder there. Huntington's disease, which is another genetic disorder, and then prion disease. So this is an infectious disease caused by a prion. Mad cow disease is one of these. So the nursing process for people with neurocognitive disorder, we want to do a history, look at the personal history of the person, the family history. If they have a history of cardiovascular disease, is there another reason why we may have a dementia process going on? Or does this look like it might be Alzheimer's dementia? Is there family history that might explain this? Then there's a physical assessment and testing. So labs, CT scan, MRI, EKG, the mental status exams. They may need a psychological exam. And then because the patient may not be a good historian, we also need information from family and significant others. The reason that labs are done are to evaluate for other reasons why this might be happening. So we're looking for infection, the liver and kidney function, if they have diabetes, any electrolyte imbalance, any endocrine disorders, nutritional issues, or the presence of any toxic substances like a heavy metal poisoning that could cause the same symptoms. So scans and other testing, an EEG to look at the brain waves, CT or MRI to look for any structural differences, a PET scan that shows the brain metabolism. If we think it might be an infection, an evaluation of the spinal fluid may be necessary. And then psychological testing, just to see what kind of underlying mental health issues the person might possibly have. So desired outcomes for the patient is that they are physically safe, they have not harmed themselves or others, maintain reality orientation as they are able, being able to communicate with their caregiver that they have on a consistent basis, being able to complete ADLs, possibly with assistance if necessary, and to be able to discuss positive aspects about themselves and their lives, kind of reminiscing. So possible nursing diagnosis is safety issues, and these are going to change as the patient declines. So it may start with some this depression in the early stages. It may move to possibility of danger of harm because of behaviors, inappropriate wandering. We hear probably every year at least one person in the news who has wandered away from home inappropriately dressed in the wintertime, and that happens. There are others, and I'm sure you can come up with a bunch of them. Nutrition gets to be a problem, self-care gets to be a problem, aggression to others can be a problem in the later stages. And this is a list of the problematic issues for care. Agitation can happen in the late stages, wandering behaviors, being unable to communicate or unable to understand, psychotic symptoms, self-care deficits. And so we need to have interventions for all of these different problematic issues. So while we have no cure for dementia, there are a couple of medications that are commonly used. There are some other medications being worked on. There was a new one that was released probably in the last year, but the outcomes don't seem to be very promising. Namenda and Aricept are two very common ones. Namenda is a NMDA receptor antagonist, and Aricept is a cholinesterase inhibitor. Other medications that we may see, medications to treat things like agitation. I'm sure you've seen that in the meds to treat psychosis, that they are not indicated for the elderly. They can cause black box warning sudden death in the elderly. Those medications are still used because sometimes they are just necessary for the patient to be able to get the care that they need because of behaviors. So you have to look at the benefit versus risk of those medications. So education is a very important part of this, both for the patient and the family. If you think about the patient getting education, that should really start in those beginning stages, so the patient is able to understand and make some decisions. if they don't understand what's going on with them until later stages, they're unable to give you a clear indication of what they would like their care to be. Um, in the early stages, they're still able to decide who they want to make medical decisions for them, decide what kind of treatment they would want. So that's when they should be making a living will, healthcare power of attorney, to be able to make some of those decisions to let their caregivers know what type of care they desire when they're unable to make those decisions and who they want to make those decisions for them. They need to be educated, both patient and family, on the disease. And referrals for evaluation. There are doctors who specifically deal with geriatric issues, so follow-up is important. The mental status exam that they do for diagnosis can be repeated at subsequent appointments, and that was a good way to track decline in brain function. Support group for caregivers is a huge thing. If the family is going to be the caregivers for this person, it's a long, hard job to take care of someone who has dementia, especially Alzheimer's dementia, where it is a long process. So caregivers need support groups so they can talk about the issues they have with caregiving. They need to know what kind of help is available to them as the illness progresses, what kind of help that they can get. Dementia is now something that can be referred to hospice. It didn't used to be because you had to die in 6 months, and that's not what happens in dementia. But that changed a few years ago, and so it is included in hospice. So the late stages they can get hospice care. So that's people who come in and help you with physical care, with emotional support for you, services that you need in your home if you're taking care of someone. In terminal phases, also nursing homes are often a place where someone ends up here, and actually hospice can be done at the nursing home also. Just a little bit different setup, but hospice also takes care of patients who are in the nursing home. They do not take care of people who do not have a caregiver, so they have to have a caregiver with them at all times to be eligible, or be in a nursing home or a hospice home.